Thank you Dr. Samsurin Halim, Dr. Seva, and Dr. Nafrialdi for the excellent discussion on recent issues in fungal infection. Ladies and gentlemen, we will now get into our 15th session. In this session, we will hear Dr. Arto Yuwono, spesialis penyakit dalam, konsultan pulmonologi, and Dr. Tan Ban Hok on update in severe pulmonary infection. Moderating this session will be Dr. Mira Yulianti, spesialis penyakit dalam, konsultan pulmonologi. Dr. Mira is a medical staff at Division of Respirology and Critical Care, Department of Internal Medicine, Faculty of Medicine, Universitas Indonesia, Dr. Cipto Mangunkusumo Hospital. Without further ado, Dr. Mira, the floor is yours. Hello, Dr. Mira. We cannot hear your voice, Dr. Mira. Dr. Mira. Is there trouble with your headset, doctor? Maybe? Dr. Mira?
What about now? Can you hear my voice?
Yes. Yes.
Clearly.
Okay, sorry. Okay. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, good morning. Thank you for all the participants of Jakarta International Chest and Critical Care in Internal Medicine all over Indonesia who are still consistent to follow, to watch the episodes of Jiccim 2021. In this session, I am so honored that I have an opportunity from the committee to chair this session where we have our two senior doctor, two senior colleagues, Dr. Arto Yuwono, spesialis penyakit dalam konsultan pulmonologi, and Professor Dr. Tan Ban Hok from Singapore. Thank you, Dr. and Professor Tan Ban Hok for joining this session with us. For the first session, we will have Dr. Arto that will speak about MDR pathogen, but MDR pathogen pneumonia. Dr. Arto is now the head of Indonesian Society of Respirology and Critical Care Association, and now he's also the head of Division of Respirology and Critical Care of Department of Internal Medicine in Universitas Padjadjaran, Rumah Sakit Hasan Sadikin. Oke, Dr. Arto, the floor is
sebenarnya yang tinggi itu kurang bagus itu. Yang depan itu dok. Iya. Kurang bagus itu. Cuman saya ngasihnya bagus karena makanya kan beda.
For the committee, the voice, your voice is now in the meeting, in the webinar.
Bismillahirrahmanirrahim. Thank you, Dr. Mira, for the introduction, and thank you for the committee for the opportunity. Can you see my slide?
Yes, doctor, very clear.
Okay, and now is the slide moving?
Yes, the slide is moving.
Thank you. My talk will be severe, as already mentioned by Dr. Mira, is about severe pneumonia with MDR microorganism. This is the outline of my talk. First, I will talk about the burden and diagnosis of pneumonia, and then the classification of pneumonia, severe pneumonia criteria, the problem of MDR microorganism, and what guideline tells about antibiotic treatment for pneumonia, including MDR microorganism and the positioning of Ceftazidime avibactam, of course. Actually, Sir William Osler already mentioned that pneumonia is the captain of the man death because the prominent cause of mortality, and that in that era of Sir William Osler. But despite the advantage and also the improvement in the treatment of pneumonia, it is still until now became the one of most prominent, the number 4, according to WHO in 2019, as the cause of mortality globally. Yeah. But in Indonesia, it is almost the same in Indonesia. We divided to, I think it is the same, yeah. Infeksi saluran pernapasan bawah and pneumonia is the same pneumonia, yeah. If we sum those infeksi saluran pernapasan bawah and pneumonia, it will be 7.4%. So it will be the number 3 as a cause of mortality in Indonesia. And on the other side of the world, yeah, in the US, HAV and VAV, which is the subset of pneumonia, is a leading health care associated infection. It is replacing the urinary tract infection to become the number 1 healthcare associated infection in the US. What is pneumonia? Pneumonia diagnosed when we found infiltrate or development of new infiltrate on chest radiograph with sign and symptom which suggests that the infiltrate is caused by infection. What is the sign and symptom of infection? It is new onset of fever, sputum became purulent, more purulent, or change color, and leukocytosis or leukopenia. It is, we must remember that it is important, yeah, because a lot disease that can cause infiltrate or in chest radiograph. This is the example for an infiltrate in chest radiograph that resembling pneumonia. What is severe pneumonia? According to the ATS IDSA criteria in 2007, and also they also mentioned in 2019 guideline, severe pneumonia has 2 minor criteria. First is major criteria. Major criteria, it is enough one of major criteria to be said as severe pneumonia. First is septic shock with need of vasopressor, and then respiratory failure requiring mechanical ventilation. And if we use minor criteria, there should be 3 of minor criteria to be said as the pneumonia is severe. Or specifically for community-acquired pneumonia, we can use CURB 65 criteria, which is the abbreviation of C is confusion, U is BUN, and respiratory rate, blood pressure, and age. If the score 4 or 5, more than 4, more or the same than 4, it is classified as severe pneumonia. If we use the CURB 65 in CAP patient. Also in CAP patient, we can use the port prediction rule. If the score of this port prediction rule is more than 130, it is classified as class 5. It is severe pneumonia and must be hospitalized in the ICU. Classification of pneumonia is based on where the patient get the pneumonia. If the patient acquired the pneumonia outside the hospital, it is said that he or she got the community-acquired pneumonia. If and hospital-acquired pneumonia is defined if upon pneumonia occurs 48 hours or more after admission, which was not incubating at the time of admission and not associated with mechanical ventilation. And what is ventilator-associated pneumonia? A pneumonia that arises more than 48 hours after mechanical ventilation. And there are 2 other terminology. First is the ventilated HIP, or pneumonia that occurs 48 hours or more after admission, yeah, not associated with ventilation at that time, but subsequently require mechanical ventilation. It is called the ventilated hospital-acquired pneumonia. And then also ICU HAP, that defined as a pneumonia that occurs 48 hours or more after ICU admission. Number 2, 3, 4, and 5 is called as the nosocomial pneumonia. So basically, pneumonia is divided on community-acquired pneumonia and nosocomial pneumonia. Why this is it so important to divide pneumonia acquired to the where the based on where the pneumonia is acquired? Because when we are moving rightward to HAP and VAP, the risk of NDR pathogen to be the cause microorganisms is increased, and also the morbidity and mortality is also increased. What is multi-drug resistant pathogens that earlier mentioned here? The acronym of that pathogen is SKP pathogen. It is consist of vancomycin-resistant Enterococcus faecium, Staphylococcus aureus, which is methicillin resistant, and then extended spectrum bacterial lactama, so ESBL producing Klebsiella pneumoniae. The K is for Klebsiella pneumoniae, and the A is for Acinetobacter, and the P is for Pseudomonas aeruginosa with multi-drug resistant, not wild type, of course, and then the Enterobacter species for E. What is the importance of the resistant? It will increase the mortality. Of course, it will increase the mortality. We can see here, yeah, resistant strain will increase 2 to 3 times mortality when compared with sensitive strain. We can see here, for example, is carbapenem resistant Klebsiella pneumoniae will increase more than 3 times compared with sensitive strain. And also, beside increased mortality, MDR pathogen will increase economic cost, of course, because yeah, the MDR pathogen usually is resistant and then need more costly antibiotics. What is the resistance for microorganisms? What is the risk factor for microorganisms to be resistant? There are a lot of factors. I mentioned here baseline characteristic, epidemiological background, recent or less than 3 months antibiotic therapy, prior colonization, and indwelling devices such as urinary catheter, etc. Yeah, but specifically for pneumonia, yeah, the ATS-IDSA or ATS-IDSA mentioned that risk factor for multi-drug resistant pathogen is first is risk factor for MDR-PAP. There is a prominent risk factor here is prior IV antibiotic within 19 days. These factors became risk factor for MDR-VAP, MDR-HAP, MRSA, and then MDR Pseudomonas VAP and HIV. Other risk factor for MDR-VAP is septic shock at time of VAP, LDIs preceding VAP, hospitalization 5 or more days prior to the occurrence of VAP, and acute renal replacement therapy prior to the VAP onset. How about the empiric antibiotic treatment? I mentioned here the IDSA and ITS 2019 empiric treatment recommendation regarding the ventilator-associated pneumonia and hospital-acquired pneumonia. First, they emphasize the use of antibiogram to guide empiric treatment. The antibiogram is very important to be local, hospital specific, even unit specific. So, because the antibiogram may be different between one ward to another ward, especially to ICU, and must be population specific ideal. It is different, the antibiogram in PAP and CAP, of course, yeah, regularly updated and disseminated. And empiric treatment that we give ideally should always be informed by local distribution of pathogen and their susceptibility. You must remember local distribution, local, yeah. And empiric regimen should also always cover, yeah, if we talk about the VAP or HAP, should cover MRSA, Staphylococcus aureus, Pseudomonas aeruginosa, and other gram-negative bacilli. In giving antibiotic, yeah, Yeah, as already mentioned, we must always include the coverage for Pseudomonas aeruginosa, other gram-negative bacilli, and then also MRSA. Yeah, in giving antibiotic treatment empirically for PAP, we should give two Pseudomonas aeruginosa coverage if there are risk factors for MDR-VAP, such as prior IV antibiotic, as I already mentioned earlier, septic shock at the time of VAP, RDIs preceding VAP, hospitalization more than 5 days, and ARRT prior to VAP onset. Local gram-negative resistance more than 10% for single agent use, and then local gram-negative resistance unknown. So if we do not know the resistant local gram-negative pattern, we have to give two Pseudomonas aeruginosa. But of course, we must do it with cautiously and prudently, not just like that. And then structural lung disease, for instance, such as cystic fibrosis and also bronchiectasis. If these factors, we do not found these factors on those patients, yeah, we use just only one agent if non-present. So for VAP, the initial antibiotic will be first piptazo, cefepime, ceftazidime, imipenem, and the most important agent is used. The most usually used is meropenem and also aztreonam. If we found the risk for MRSA in that patients, add one of the following, either vancomycin or linezolid. But if we do not find the MRSA risk factor, we think that the cause of Staphylococcus aureus is MSSA, it is enough to use just one disk of antibiotic. If we also found that the Pseudomonas risk for MDR, Pseudomonas aeruginosa, add one of the following. So if we found the risk of MDR, Pseudomonas aeruginosa, and the risk of MRSA, we should use one from this, and one from this. We should use empirically 3 antibiotics. 2 of them is to fight against Pseudomonas and other MDR gram-negative, and 1 is to fight the MRSA. How about HIV, hospital-acquired pneumonia? We use 2 agents for Pseudomonas aeruginosa if we found the following risk factor for MDR HIV, HIV, high risk of mortality, ventilatory support due to AV or septic shock, structural disease, and numbers of prevalent gram-negative bacilli on gram stain. If we do not find this, use one agent. Yeah. So in treating HAP, we divide the patient to 3 groups. First, the patient with not high risk of mortality and no risk of MRSA. Second group is not risk high of mortality, but with the risk of MRSA. Kemudian, and then high risk of mortality. The third group is high risk of mortality with IV antibiotic within 19 days. If there are no risk of high risk mortality, which is ventilatory support or septic shock, need ventilatory support or septic shock, use only one antibiotic. So not all HAP use 2 antibiotics. It is frequently only need 1 antibiotic. So do not automatically give 2 antibiotic for HAP patients. Yeah. And then if no high risk of mortality but with MRSA, we should add vancomycin or linezolid. And if high risk of mortality, such as ventilatory support, HIV, or septic shock, and there are a risk factor for MRSA, we should 2 of the following, but not from the same class of antibiotic. So, for instance, we could not give piperacillin and piptazo and cefepime as a combination, but instead of that, we use, for instance, meropenem plus levofloxacin or meropenem plus amikacin. The duration of therapy, IDSA, IDS guidelines mention that it is enough 7 days. Yeah, study shows that there are no difference in outcome if we give the antibiotic 7 days compared with 14 days. And this is also recommended for HAP, not for AP, not only for VAP, but also for HIV. This is also includes for Pseudomonas and also for Acinetobacter species if the culture reveal that that microorganism. Yeah. What is the importance of empiric antibiotic therapy? There are several facts that mortality rates are higher if the initial empiric rate was inadequate. Yeah. So the initial empiric antibiotic therapy has to be adequate. Yeah. In severely ill patients, the initial empiric therapy is the most important decision a physician ever made. Yeah. Yeah, of course, this is understandable. If we are not give inadequate or inappropriate therapy, the mortality will increase and also the cost will increase. Not just only mortality, but also the cost is increased. Regimen should include agents that are from different antibiotic class than the patient has recently received. So, for instance, yeah, patient from outside came to our hospital already given the usually the most popular antibiotic is levofloxacin. So, it is better if we do not give the same antibiotic from that class, from fluoroquinolone. So we have to give antibiotic that came from different antibiotic classes. For instance, beta-lactam and also maybe aminoglycoside. Yeah. Changing antibiotic therapy once culture results are available may not reduce the excess risk of hospital mortality due to inappropriate initial antibiotic therapy. So, if we give the empiric antibiotic therapy inappropriate, it will reduce the survival. It will increase the mortality, and that will not reverse if after the culture is the culture result is came, and then we change the antibiotic regarding the culture, it will not increase the survival or reduce the mortality significantly. So it is very important to give empirical antibiotic therapy adequately and appropriately. Yeah. So getting antibiotic at the right at the first time is very important. Early antibiotic therapy is very important. If we delay the antibiotic empirical therapy, it will increase the mortality. It will reduce the survival 7.6% every hour we delay the therapy. So we should give the antibiotic in the ER room, not waiting until the patient is came to ICU or to ward. Yeah, it is better if we give antibiotic as soon as possible after the diagnosis is already made. Yeah. Now we are talking.
5 minutes, Dr. Arto.
Thank you very much. Thank you very much, Dr. Mira. Yeah, yeah. This is my several final slide. Now we are talking about the ceftazidime avibactam. Yeah, avibactam is first class of novel beta-lactamate inhibitor. It is the older, yeah, clavulanic acid, tazobactam, and sulbactam is structurally related to beta-lactam, cause acetylation and subsequent irreversible inactivation by beta-lactamase. Avibactam, yeah, is first in class non-beta-lactam beta-lactamase inhibitor. This is the came from the azabicyclooctan or TBOs. It is different from the previous three. Yeah, it does not have beta-lactam skeleton, so low propensity for hydrolysis and expanded spectrum of beta-lactamase inhibition, and mechanism of inhibition is reversible, and also has a broader spectrum of beta-lactamase inhibition. Yeah. Ambler classified beta-lactamase as A, B, C, and D. We can see here that avibactam only cannot cover only the class B or beta lactamase, yeah, uh, but the group A, C, and D is covered by the avibactam. This is a study of phase 3 clinical trial regarding the role of ceftazidime combined avibactam combined with ceftazidime compared with meropenem. The study name is REPROVE study. It is include 879 patients, which is randomized to cefta-avi and also to meropenem, and several patients has to be roll out, but the result is 355 and 363 in this group. And the result that is mentioned that ceftazidime avibactam was not inferior to meropenem for treatment HIV/HIV in this setting. It is not inferior at all compared with meropenem. How about the clinical cure rate and microbiological response rate? Also similar between patient receiving ceftazidime avibactam compared with patient receiving meropenem. How about the safety between both? It is similar, yeah, both and mostly mild, yeah, and unrelated to study treatment. Usually diarrhea, hypokalemia, anemia, constipation, and vomiting. So as a summary, nosocomial pneumonia, which is consists of hospital-acquired and ventilator-associated, frequently severe and caused by MDR microorganism. MDR microorganism increase the risk of inappropriate, inadequate initial empiric antibiotic therapy. Of course, yeah. Initial appropriate and adequate antibiotic therapy increase the mortality and economic cost. Empirical antibiotic therapy should always informed by local distribution, ideally, but I'm not sure in Indonesia, yeah, in most hospitals in Indonesia, yeah, and should always consider MRSA, Pseudomonas aeruginosa, and also Acinetobacter. Recommended duration therapy is 7 days. Efficacy and safety of ceftazidime avibactam not inferior compared to meropenem in treatment of nosocomial pneumonia, in this case HIV and PAP. So with that, thank you very much for this opportunity. Thank you, Dr. Mira.
Thank you, Dr. Arto, for your comprehensive and clear explanation. And now maybe we can move to our next presentant, Professor Tan Van Hoek. Thank you, Professor Tan Van Hoek, for joining with us this morning. How are you?
Thank you.
Okay.
Thank you very much for the invitation.
Okay. Professor Tan Van Hoek is a very senior consultant in NUH, and now he's a senior consultant, Department of Infectious Disease, Singapore General Hospital, and a clinical professor from Duke News Graduate Medical School. Professor Tan Van Hoek, the time is yours now.
Thank you. So thank you very much to everyone for the opportunity to speak at your symposium today. Could I have my slides, please? And thank you that this part of the symposium conference is in English. Do I? Oh, I share my slides, is it?
Yeah.
Okay, sure. Just a while. Sorry, I hadn't realized that. I'm going to have to speak quickly because I have a lot to cover, but I hope there will be time for questions. Yeah, coming. Okay, so how do I do that?
You can press the share screen button. Okay.
Are you seeing the slides now?
Yes.
Okay. Can we see the slides now?
Yes, we can
Yeah.
see.
Okay. Thank you very much. Okay. So let's start. Yeah, this is what, these are my disclosures. So today I will start with acute invasive aspergillosis in a compromised host and focus primarily on patients with hematological malignancies because that's probably the best studied category of patients. I will then talk about invasive aspergillosis in the immunocompetent host, and this is an emerging topic, as you all know. And then I'll touch on chronic pulmonary aspergillosis. So despite the title, acute and chronic aspergillosis are actually part of a spectrum. This is not progression. So they are all different diseases, but caused by the same fungus. And essentially, the type of manifestation depends on the immune response. So, you know, it's like different cats. They're all members of the same species, but they look different. So we'll start with this 50-year-old Indian man, and basically he has got multiply relapsed lymphoma. And as you can see, it's an illness over 15 years. There are quite a few good years when he was in remission, but now he comes in and he's admitted for this R-ISHAP. And as you can see, he very quickly becomes neutropenic, and interestingly, he develops cough, runny nose, sore throat. This is pre-COVID, of course, so it's not COVID. It was influenza. And this is the progression of his X-rays and how it started. That's number 2. And you can see here that it is not really typical of an influenza pneumonia. There are quite a few nodules. And at this point, his fever rages on in spite of oseltamivir and meropenem. So that's the reason for referral to the ID physician. Then the CT is done. And as you can see, there are actually disparate nodules. This one might have a halo, this one might have a tiny cavity, and soon he deteriorates and has to be intubated. And actually, even a simple gram stain from his ETT shows hyphae. And when they go on to do a BAL, the fluid has got a very high galactomannan level and gross aspergillus. So the issue is whether or not we have clinched the diagnosis, academically speaking. Clinically, of course, we have. There's none of us who have withheld an anti-mole agent. But I just thought of walking you through the guidelines, the criteria for diagnosis of invasive aspergillosis in the compromised host. So this was updated just last year. And basically, there are 3 categories that you have to fulfill before you can, in a sense, confirm the diagnosis. So the host, some clinical features, and the mycologic features. Now the host, you know, people on high-dose steroids, people who have had a solid organ or bone marrow transplant, and people who have had a prolonged neutropenia. For mycologic, these are the microbiologic features, and basically they take serum and BAL galactomannan. And finally, clinical. Now, the clinical one is where pulmonary aspergillosis is concerned. Is actually very interesting. They limit themselves mainly to radiological features. So number 1 would be nodule with halo, as you can see. Number 2 is the presence of a cavity, presence of air crescent sign. And in the latest version of the EORTC guidelines, wedge-shaped pleural base consolidation, which, as you know, is typical of infarction. And that's because invasive aspergillosis in the compromised host is really an angioinvasive disease, and there will be pulmonary infarction. Now, the definitions are a means to advance research. So if you're going to write a paper, you would have to make sure that the patient fulfilled all the criteria. You can enroll patients in clinical trials based on the criteria. But in real life, like I said, if you see nodules in a compromised host, most of us would act and start an anti-mole agent first. Now, how do we treat? This is a good guideline from the Europeans also. I have highlighted the treatment for pulmonary aspergillosis in the very compromised people, neutropenic and allo-SCT patients. And as you can see, they have actually placed isavuconazole slightly above voriconazole, but of course both are A1. So we all are very familiar with voriconazole. I think it's already generic in many countries. So we'll talk a bit about isavuconazole. This is the registrational study that was published in the Lancet a few years ago. And you can see that whatever outcome you take, whether intention to treat analysis or modified intention to treat. Modified intention to treat usually means people who have proven or probable only. You can see that there was really no statistical difference between those randomized to isavuconazole and those randomized to voriconazole. Possibly, mortality looks slightly lower numerically, but really statistically there was no difference. And many of us sort of move towards isavuconazole these days, mainly because of the safety data. I think all of you who have used voriconazole would know that it's really quite a tricky drug to use. The patients get visual problems, the door instead of brown appears blue, they get hallucinations, and of course the LFTs become abnormal. On an outpatient basis, you would have to check the ECG at every visit because of how voriconazole can prolong the QT interval, whereas isavuconazole has much less of these side effects. And interestingly, isavuconazole is one drug that shortens the QT interval. I think only this year, this study was published. This is POSA versus VORI, also a very big study. And as you can see, whether you take the 42-day all-cause mortality or what they call the full analysis set, meaning only those with proven and probable disease, again, there was no difference between those randomized to posaconazole and those randomized to voriconazole. Although you can say that the mortality at the 6-week mark was possibly better in the POSA group. And again, in terms of side effects, POSA appeared to be slightly better, 6% versus 10%, although again, not different statistically. So I think the guidelines will change. Isavuconazole and posaconazole and VORI will all appear as A1 with some preference for the other two over VORI. So let's change tack. This is a 40-year-old man who has fever, chills, rigors, and cough. And again, these were pre-COVID days, so no points. He had influenza. This person is a competent host. His community living. We're not talking about a leukemic now. And his x-ray is quite bad. And as you can see, he goes on to be intubated. Here's the ETT tube, but somehow he manages to recover. He goes to rehab. It's a very long stay. And one day he develops a fever. This is his new x-ray. And as you can see, there's actually consolidation with the cavity, and on TTNA, it's a fungus. So I think we are seeing more and more of severe patients with severe influenza in the ICU who develop aspergillus. It's still not very common, but it's something to look out for. And this panel of experts, once again from Europe, have come together to figure out how you would clinch the diagnosis. Clinching the diagnosis is important. Voriconazole has many side effects. It continues to be expensive. If you use isavuconazole, that's a new drug, so still fairly expensive, right? So if there is tracheobronchitis, that means if you have put in a bronchoscope and you notice a pseudomembrane or an ulcer, then it's very easy, whether it is serum or BAL, GM or culture, anything will help you clinch the diagnosis. But if there is no tracheobronchitis, then of course, obviously there has to be a pulmonary infiltrate and at least one of the following. And as you can see, when there's a pneumonia, the guideline insists that, and if you only have a culture, it has to be a BAL culture, not just an ETT aspirate. That's because of the issue of colonization, Aspergillus colonization, which is quite common in many healthy people. But if you have a cavity, then any culture is fine. But note that pneumonias like MRSA and Pseudomonas sometimes produce cavities, so it is important to rule out all these other conditions. So as you can see, more and more people are recognizing that in the ICU, critically ill patients are actually a new risk group for invasive aspergillosis. This is data from this Belgian university where they do a very high rate of autopsies in the ICU patients. And they found that aspergillosis was the cause of death, or at least a contributory factor in 15% of their autopsies. And when they eliminated all the patients with an underlying malignancy, there were still other patients who had no cancer but who had aspergillosis. Some we know are immunosuppressed, like organ transplant recipients, patients with autoimmune disease who are on various immunosuppressives. But as you can see, there's someone with COPD, there are people with cirrhosis. And so this group came up went on a search for aspergillosis in the ICU. They devised some criteria to include patients, and then they got 30 ICUs in 8 countries to participate. And instead of the word probable that was used in the AOR-TC criteria, they used the word putative. That means, yeah, you can sort of say it is. And as you can see, about 300 patients recruited from 30 ICUs. That's each ICU probably was contributing only 10 over a 10-year period. So each ICU maybe contributed about 1 per year. So actually a very uncommon disease, but we know it's devastating. And if you look carefully at all the individuals who were diagnosed to have either putative or proven aspergillosis amongst this very large cohort of ICU patients, actually a full 3/4 of them had a host criterion that was not classifiable by EORTC. So you don't need to be that immunosuppressed to get invasive aspergillosis. Now, if you look at all these series, sorry, I don't have time to go through them, you find that patients with COPD tended to be one of the more common hosts getting invasive aspergillosis in the ICU. And there are many such case series. I don't have time to go through, but people have come up with criteria. And I think in this setting, steroids are playing a role, in addition, of course, to the fact that when they have mucociliary damage from smoking, they're not clearing the airways properly. This is another category of patients whom we are beginning to see are at risk of aspergillosis, people with acute fulminant hepatitis. This is another study, severe alcoholic hepatitis. Once again, we all know that when there's severe fulminant hepatitis, there's some neutrophil dysfunction, but alcoholic hepatitis patients are at particular risk because when it's severe alcoholic, they are treated with methylprednisolone. And of course, I cannot run away from this topic. We live in these COVID times, and all of you must have heard that aspergillosis can complicate severe COVID in the ICU. And a guideline also has appeared. So let's move on to the third category. This is a man who's been my patient since 1999. He's known to have Marfan syndrome. He's had bilateral pleurodesis for pneumothorax from about age 20, which was 20 years before I first knew him. And he came in with CT like that, and multiple sputum cultures were negative, but all with Mycobacterium avium complex. So he was treated for MAC, he could not clear, and I subjected him to a left upper lobectomy. And in 2005, so he had about 6 good years, he had the recurrence of MAC and he was retreated. So the left upper lobe is gone, but this disease must now be in the right upper lobe. And then he had quite a few more good years, but now he comes in with hemoptysis, a workup for acid-fast bacilli and TB. All those were negative, but he has aspergillus in several sputum samples. Galactomannan was negative. I wanted a BAL, but as you can see, his lung function is really not very good, and the chest physician thought that it was a bit too risky, but his aspergillus precipitins were positive, and he was treated for chronic pulmonary aspergillosis with good response. He just came back with a recurrence, but you know, he's been okay for the past 8 or 9 years. So this is chronic pulmonary aspergillosis. It's actually a complex of overlapping syndromes. We all know about the simple aspergilloma, but now people are recognizing that in some cases, aspergillus can just present as a nodule, almost like a cryptococcal nodule on the chest X-ray. And then there's chronic pulmonary aspergillosis, which is divided into the chronic cavitary forms as well as the chronic fibrosing forms. And then when it's sort of more rapid, there's something called CNPA, chronic necrotizing pulmonary aspergillosis, or the term proposed by David Denning, who is a guru of aspergillosis, is subacute invasive aspergillosis. So this is a clinical syndrome, and basically you have got to have 3 things: the symptoms, which can be a combination of respiratory and systemic symptoms, cough, hemoptysis, weight loss, generally lasting for quite a few months. There should be some cavities on imaging, usually with a paracavitary infiltrate. Fungal ball is not necessary, but it's good to have. And of course, there has to be some sort of evidence of aspergillosis. So for the microbiologic criteria, this guideline, which is about 5 years old by now, suggests that it's good to have this, you must have this Aspergillus IgG or the presbytins. I think this is the key microbiologic criterion. You can have antigen or DNA that has to be strongly positive, not just any. If you manage to persuade the chest physician to biopsy the patient, you will be able to show high Phe on microscopy. Sputum culture by itself is inadequate. Now, this is one of the most difficult diagnoses to make. As in the example I gave, you have to rule out TB and non-tuberculous mycobacteria. And then in the country with histoplasmosis like Indonesia or the US, or cocci, then you know that those diseases may present like that, upper lobe infiltrates with cavitation. And then when the patient is coughing a bit more than usual, you would have to obtain standard cultures and just make sure that there isn't super infection with Pseudomonas or Haemophilus influenzae, right? Because these are people with destroyed lungs and bronchiectasis and lots of cavities. So TB or non-tuberculous mycobacteria may precede, follow, or occur contemporaneously with chronic pulmonary aspergillosis, and when you've confirmed one, you haven't excluded the other. So did my patient have chronic cavitary or chronic fibrosing pulmonary aspergillosis? Well, in simple terms, simplistically speaking, chronic fibrosing is just the end result of untreated CCPA. Now, what about a resource limited setting? What if you don't have access to many different diagnostic modalities, right? So basically, then they are more relaxed. Any Aspergillus antibody is fine. They accept sputum microscopy, and if you don't have access to antibodies, then at least a sample, but then there has to be Aspergillus growing from 2 separate sputum samples. Now, in our practice, I think for those of us who work in a tertiary hospital, this is very worrying. When we see a lesion like that, we really don't know whether it's aspergilloma or cancer, and we really don't want to be foxed. So this is a paper, I think this is Korean, and they suggest that you use Hounsfield units, pre and post enhancement scans, And you find that here in the enhanced scan, there was not much increase in the intensity in the Hounsfield units, and this was an aspergilloma. Whereas this is cavitating carcinoma of the lung, and you find that it enhanced by a lot from 35 to 48. And when they did the analysis, they found that significant contrast enhancement in excess of 10 Hounsfield units was statistically significant for cavitating lung cancer. The other one, adjacent bronchiectasis, on the other hand, would favor an intracavitary aspergilloma. So like I said, serology is the key microbiologic criterion for the diagnosis of CPA, and many different kits are available on the market. All are quite good, as you can see from this study. And in Indonesia, my good friend Retno Wayoningsi has studied this LFD Bio, and they have found that it's really quite good if in patients with chronic pulmonary aspergillosis, definitely positive and probably negative, and those who don't have, largely negative. Sometimes it's positive, but as you know, you have to have other criteria like symptoms in excess of 3 months and weight loss and etc., and the correct type, cavitation with paracavitary infiltrates, etc. So a helpful tool. Now, what about serum galactomannan? It's actually not a very good test. These authors think it's actually poor, but you may still want to use it in your armamentarium. Some of them are positive, and if you know that if you can exclude the causes of false positive, you can take that as supporting evidence. How to treat chronic cavitary pulmonary aspergillosis? This is probably the only RCT suggesting that itraconazole is better than just supportive care. Supportive care is like, chest physio and mucolytics and pulmonary rehab. But people are also talking about the use of voriconazole. So I think there are a few Japanese papers where they have done open label, they have open label data to show that voriconazole worked. So in summary, the most severely immunocompromised patients are at risk of invasive aspergillosis, but we are now recognizing new categories of patients who are also developing aspergillosis. Almost all of these are occurring in the ICU. And of course, we should also learn to pick up chronic cavitary pulmonary aspergillosis, but I find it a very difficult diagnosis to make. Radiologically and symptomatically, the patients really look like patients with TB or non-tuberculous mycobacteria. So thank you very much.
Okay. Thank you very much, Professor Tan, for your very interesting presentation. There's a lot of things that we learned from your presentation. Thank you again. And I think we move to the discussion. Is Dr. Arto still with us? Okay.
Of course, Dr. Mira. Okay. Sorry. I forgot to unmute.
It's okay. Thank you. Now we move to the discussion. Due to our limited time, maybe I just skip 2 questions here. There's a lot of questions actually. Now it's for Dr. Arto. When do you think the right time to give the Sesi avibactam to our patients, since it is still not in any guidelines now?
Yeah, I think the best time to give the it is not in the guideline yet, but actually the spectrum is good enough, but as the partner of the avibactam is the ceftazidime, so the coverage of the ceftazidime, which is mostly to gram-negative bacteria, microorganism. So it will be best for HAP or VAP patients. Yeah. It is also meant to an agent as a carbapenem sparing agent. So if we always use the carbapenem, so it will create the carbapenem resistant microorganism. So it will be problem when we find the ESBL. So this ceftazidime avibactam, maybe it is better to replace, not replace, in some cases replace the role of meropenem. For HAP and VAP patient, of course, do not use it in community-acquired pneumonia patients.
Okay. For the HAP, for the high risk HAP, maybe Dr. Arto. And then another question, sorry, for Dr. Arto. What antibiotics are recommended to treat sepsis due to MDR Acinetobacter baumannii HAP VAP in COVID-19 ICU patients?
Yeah, we are not seldom to find this. Yeah, find this. But if we already know the susceptibility test, use the susceptibility test. That's the best. Yeah. But if we do not know the susceptibility test yet, we can maybe use tigecycline or sometimes combine with fosfomycin. And the last armamentarium is colistin. But we should use it cautiously. Yeah. Do not use imprudently. Okay.
Thank you, Dr. Arto. And for Professor Tan, do you think, what is your suggestion for treatment options for aspergillus with severe liver problems?
Liver problems?
Yes.
This is very, very difficult.
Yeah.
If you have voriconazole, you can use low doses like 100 a day, but you would need access to therapeutic drug monitoring, and it should come back quickly because you need to adjust the levels, because we know that voriconazole itself can be hepatotoxic. If you can access isavuconazole, that's a much safer drug, of course. If not, good old ambisome is an option. But a lot of liver failure patients also have hepatorenal syndrome. So we are really in a very tricky position here. That's what I feel.
So we can try first with low dose voriconazole, and
You
then
can try, yeah. But you have to check levels, make sure you don't overshoot.
Okay, and then
and there are publications supporting that. I think got a few papers from China, I think, because they have a lot of Hep Bs that go into acute fulminant.
Oh, I see. Thank you. Okay, thank you, Professor Tan. Okay, and for another question for Professor Tan.
Yeah,
Sorry.
please.
Yeah. Like for Dr. Arto, when is the right time you suggest to give isavuconazole for aspergillosis patients? Because it is told the IDSA ATS still recommend voriconazole for the first line empirical treatment.
So like I said, yeah, that's a very interesting question. First of all, like I showed, the Europeans have put it as one of the first line options. So you could use it from the start. And I do that in certain categories of patients. So like I said, if people are already having a prolonged QT interval, then I think we shouldn't use voriconazole. The other category would be patients in the ICU who are on CRRT or some form of dialysis. That's because the voriconazole has got that solubilizing agent cyclodextrin, and some people worry that it cannot be adequately cleared. So that's another setting. The third one is if you have a nodule or cavity in a patient with hematological malignancy, and the evidence for aspergillus is still not there. You've sent the galactomannan and it hasn't come back, or so you may want to do ISAVU first because you can't exclude mucormycosis. So I think there are some circumstances in which you can start off with isavuconazole. But most of the time, and at our hospital, because Vori is now a bit cheaper than Isavu, since it has become generic, most people will start with Vori, and then you will switch when side effects develop. Patients develop hallucination, or the ECG shows QT prolongation, or the LFT becomes abnormal. Yeah, so you can do either as a first off, or you can do a switch therapy.
Okay. Thank you, Professor Tan. Just one more questions, maybe. For Professor Tan, can we treat patients as aspergillus based only for positive galactomannan BAL results, bronchoalveolar lavage results, but negative culture for aspergillosis?
Oh yes, of course. Yeah. If you have the right host, so I think the host is very important. And you can, yeah, that's why I showed all these various criteria. And if you follow those, yeah, you'll be all right. BALGM is a good test.
Thank you again. Sorry for our limited time and the time is over. We cannot answer all of the questions from the participants. Thank you again for Professor Tan Ban Hock and Dr. Arto Yuwono for a very interesting explanation and discussion for today. Okay, I give back the symposium to the Master of Ceremony.
Yeah, thank you very much. Yeah, bye-bye.
Okay.
Thank you very much.